Hi friends, welcome to this session of discussion of previous year MCQs, where we'll be focusing on the last few year multiple choice questions that have come in the NEET PG exams and in the INI-CET exams, and we'll be focusing on the pediatric questions that have appeared in these two exams. I'm Dr. Pankaj Tikku, the pediatric faculty at eGurukul and DBMCI, and I would be discussing these questions. I've been able to shortlist around 39 questions in the last, I think, 3 years that we have seen, or 2 years. These are the questions that have appeared both in INI-CET also and in NEET PG also. So let us now start these questions. The first question is a question on a 12-year-old boy, a child who has been suffering from myoclonic jerks throughout the day since the last 1 month. So the child has a history of myoclonic jerks occurring since the last 1 month. There is also a history of the teacher reporting irritability, loss of concentration in the child. The parents gave no significant history other than a history of fever and rash that had occurred in the child about 1 year back, about 1 year of age. I'm sorry. So this is at the age of 1 year when the child had a history of fever and a rash. Now the child is 12 years of age. So although you might take this as a very insignificant history because the child is now 12 years of age, and I'm talking about a history which is almost 11 years back, when the child at 1 year of age had a history of fever and a rash, which resolved spontaneously in some days. The current EEG, when the child is having these myoclonic jerks, the current EEG shows periodic bursts of sharp, slow waves. What investigation will lead you to the diagnosis? So first, what is the condition that you may be thinking in such case? See, when we talk about a child who is suffering from myoclonic jerks and who is suffering from problems related to concentration, problems related to emotions, having irritabilities, so this appears to be some sort of a CNS problem, and given the presence of jerks also, myoclonic jerks also, some CNS problems also, it goes more in favor of something like a meningoencephalitis. Although we have not examined the child, but meningoencephalitis appears to be likely. Now, when you connect a meningoencephalitis occurring in a child 12 years of age with something that had happened 1 year back, something that had happened at 1 year of age, 1 year of age, a fever and a rash, which appeared 11 years back at 1 year of age, and the child is right now having 11 years down the line, now having a history of myoclonic jerks, signs of encephalitis, this appears to be something linked to possibly measles. So it is quite likely that when the child was 1 year of age, the child may have had that measles disease or measles infection, which is basically an infection that occurs commonly associated with the measles virus, which belongs to the family Paramyxoviridae. Now, this measles virus is associated with fever and rash typically appearing on the 4th day of fever, and it is often associated with the spontaneous resolution in most cases. There might be complications that may appear with measles, but in most cases, it will end up regressing by itself. The rashes, the fever, they all resolve by itself, and that is what happened in this child. Now, 1 year of age, the child had this problem of measles, and now 11 years later, now he's 12 years of age, he's having that problem of encephalitis. This is one of the rarest complication of measles, which is known as SSPE, or a subacute sclerosing panencephalitis. So measles can be associated in children with several complications. It can lead to acute otitis media, which is one of the most common complication of measles in children. Rather, I would say the most common complication. Then measles is often associated with diarrheas in children. It can be sometimes, very rarely, be associated with the hepatitis in children, meningoencephalitis is a known complication. Now, encephalitis can occur during the time of measles infection also, and it can occur as a type of post-measles encephalitis also, which can occur just after a measles infection. Subacute sclerosing panencephalitis is a very, very rare complication of measles, probably counted as the rarest complication of measles, which occurs almost about 7 to 13 years after a primary measles infection. So it is usually believed that SSPE occurs about 7 to 13 years after a primary measles infection. So whenever a measles infection occurred in a child, it is postulated that either the virus persists in the body even after the resolution of measles symptoms, the virus persisted and had a change in the genetic framework or an abnormal immune system along with an abnormal measles virus possibly led to the development of encephalitis like symptoms almost 7 to 13 years after a primary measles infection. This complication is known as SSPE, subacute sclerosing panencephalitis. So both an abnormal measles virus and an abnormal immune system's interaction with that measles virus, which is persisting in the body, is likely to contribute to the development of SSPE. The signs and symptoms of SSPE often are very, very difficult to identify, at least initially in phase 1. So during the first stage of the disease, when SSPE starts evolving, most of the signs and symptoms can be very, very non-specific. In fact, signs and symptoms such as irritability or signs and symptoms such as decreased attention span, many times noted by the parents, many times noted by the teachers, they all can be noted. Sometimes behavioral changes can also be noted in the child. These are very, very difficult to identify and sometimes may be probably so subtle that they actually may not be identified by the parents or the teachers. This is followed by a phase 2, which is actually a more evident phase when the child typically starts having myoclonic jerks. And this is the time when the first time often the disease comes to light. So in a child who has been having irritability, decreased attention span, behavioral changes, many of those changes may be very subtle. Gradually then the child starts having myoclonic jerks, often associated with abnormal movements of the hands and feet. This is followed by phase 3, in which the disease further evolves and the child may develop a typical chorioethitoid type of movements. Often it may also be associated with an evolving lead pipe rigidity. So the tone of the body starts increasing, a lead pipe type of a rigidity evolves, and the child may develop a chorioethitoid type of movements. Other type of abnormal movements which were part of phase 2 may subside by this time. And this is followed by phase 4, when the child finally enters into a stage where most of the critical centers, respiratory centers, blood pressure centers, which are being controlled by the brain, they start shutting down. So it's a gradual process in which this SSP evolves, starting from irritability, decreased attention span, behavioral changes, going on to develop myoclonic jerks, followed by abnormal movements, chorioethitoid movements, lead pipe rigidity of the body, and gradually then entering into a final stage when most of the critical centers start getting suppressed or shut down. The diagnosis can often be made first based upon these symptoms. So first, if you see these symptoms evolving and there is a definitive history given by the parents of a measles infection that had occurred almost around 7 to 13 years back, then you might think of an SSPE. Another way in which an SSPE can be suspected is obviously if you are able to detect IgG, IgM antibodies against the measles virus in the CSF of the child. So the child who is being evaluated, you obtain that CSF, and in that CSF, if you are able to identify IgG, IgM antibodies against the measles virus, then also you can make a diagnosis. And often the typical EEG picture, particularly this EEG picture, is very evident during the time when myoclonic jerks appear. EEG in phase 1 of this disease may be normal EEG. But in phase 2, when the myoclonic jerks appear, the typical suppression burst episodes or suppression burst waves may be seen in the EEG. The disease often is associated with poor prognosis. Often overall the disease is an evolving disease, so the treatment is usually very difficult. There have been drugs like isoprinosine, which is a drug which is known to have antiviral effects. It has often been used as an antiviral drug, particularly in the treatment of SSP. So isoprinosine, with or without interferons, have been used in some cases with some success. Also for treating the myoclonic jerks that develop during this disease, carbamazepine has been found to be an excellent drug. But overall the prognosis of this disease is often poor. So considering that this child had a feature of encephalitis like symptoms and there was a history of measles 11 years back, that is at the age of 1 year, I would think of an SSP at this stage. And for an SSP, the best way to identify is by trying to see for the presence of IgG or IgM antibodies. IgG antibodies obviously will be the ones that will be seen here, because IgM antibodies usually are the antibodies that indicate a more recent infection. So what we would be looking at is the presence typically of IgG antibodies, typically the presence of IgG. This is the one that is typically seen. IgM obviously are more indicative of acute infections. So because this disease occurred almost around 7 to 13 years after a primary measles infection, IgM antibodies are unlikely to be present, more of IgG antibodies. So typically the presence of IgG antibodies against the measles virus, if it is present in the CSF, then you can think of SSP. So therefore the best answer here is anti-measles IgG antibodies found in the CSF. IgM, as I told you, are unlikely to be present most cases because this is indicative of acute infection. IgG is the one that is persisting for long periods of time and indicates an infection in the past. So with this, we answer question number 1. Let us now come to question number 2. Question number 2 says a 12-year-old child with generalized edema, serum cholesterol of 248 milligrams per deciliter, which clearly indicates that there is a hypercholesterolemia, and a urine protein which is 3+. Now this is usually measured by the urine dipstick method. A urine dipstick method, when it shows traces amount of protein in the urine, it indicates that the amount of albumin in the urine is less than 30 milligrams per deciliter. If the dipstick shows the protein is 1+ in the urine, that normally means that the urine protein is about 30 to 100 milligrams per deciliter. 2+ means the urine protein is between 100 to 300 milligrams per deciliter. But when the dipstick method shows the urine albumin is 3+ and 4+, 3+ means the urine albumin is almost around 300 to 1000 milligrams per deciliter, and dipstick method showing 4+ means the urine albumin is more than 1000 milligrams per deciliter. So usually Urine protein, which is 3 plus or 4 plus by the dipstick method, is more likely to go in favor of a child having a nephrotic syndrome. So here we are clearly seeing that there is presence of proteinuria, and proteinuria along with hypercholesterolemia, as you can see here, along with the generalized edema, as you can see here, typically will go in favor of a nephrotic syndrome. Urine infections can be associated with hematuриas, microscopic hematuриas, but unlikely to be associated with proteinuриas. Nephritic syndrome, glomerulonephritis, can be associated with hematuриas. In fact, hematuриas are present in most of these cases, but they may or may not be associated with proteinuриas. So nephritic syndrome is associated with the hematuria, which can be gross hematuria also and a microscopic hematuria also. But proteinuria is unlikely to be present. Even if proteinuria is present, it is not a predominant feature of glomerulonephritis. A predominant feature of glomerulonephritis or nephritic syndrome is hematuria. Goodpasture's syndrome is unlikely to be seen in children. It's more commonly seen in adults and typically presents with an RPGN, rapidly progressive form of a glomerulonephritis. So there are anti-glomerular basement membrane antibodies which can damage both the basement membrane in the lungs and the basement membrane in the kidneys. But here we do not have any manifestation of hemoptysis, which is lung involvement, that is seen. So Goodpasture's is ruled out, nephritic syndrome is ruled out, urine infection is ruled out. So this is clearly a case of nephrotic syndrome. The nephrotic syndrome that is seen in children is associated with pathological proteinuria, which is defined as urine protein excretion, which is more than 3.5 grams per day, or a urine protein excretion which is more than 40 milligrams per meter square per hour, or even more than 2 urine protein to creatinine ratio. So that is another way, urine protein to creatinine ratio of more than 2. So all of these indicate that there is a pathological proteinuria, large amounts of protein that is being excreted in the urine. And most of the protein that is excreted in urine in childhood nephrotic syndrome is low molecular weight protein. So we call it as a selective proteinuria. The high cholesterol level that you see often in nephrotic syndrome in children is usually either because of impaired excretion of the lipoproteins, which is primarily because of decreased activity of the lipoprotein lipase, or it can be because of increased in the synthesis of lipoprotein by the liver. So that can contribute to an increase in the cholesterol levels in the blood seen in children with nephrotic syndrome. Plus, there is increased risk of thrombosis in nephrotic syndrome. These children often may have complications such as renal vein thrombosis. They also have increased risk of infections, particularly infections which can lead to peritonitis also, as caused by Streptococcus pneumoniae. So these are some of the features of nephrotic syndrome. So this is a child who has a nephrotic syndrome. Let us come now to question number 3. Question number 3 states a 10-year-old child presents with upper limb hypertension, lower limb pulses which are not palpable, chest x-ray shows notching of ribs. This again is a pretty straightforward question with a straightforward answer. The child has a coarctation of aorta. Now this coarctation of aorta is a congenital heart disease which is associated with the narrowing present in the arch of aorta just distal to the left subclavian artery. So if you see the arch of aorta, so at the place where the arch of aorta is merging with the descending aorta, at that place where the left subclavian artery arises, so this is the left subclavian artery, this is the place where the narrowing is usually present. So it is present at the arch of aorta where it is merging with the descending aorta, just distal to the left subclavian artery. And since this narrowing is often present near the point where the ductus arteriosus also attaches to the aorta, that is why we often call this narrowing as a juxtaductal coarctation. Juxta means near. Juxta means near. Coarctation means narrowing. So juxtaductal coarctation means the narrowing in the aorta is near the point where the ductus arteriosus attaches to the aorta. So naturally, when the blood will find it difficult to go into the lower half of the body, so the lower half of the body, because of the narrowing, receives reduced amount of blood. So obviously the lower limb pulses will be feeble or not palpable. In contrast, the blood will freely go into the upper half of the body. So for example, the right subclavian, the carotids, the blood will freely go into the upper half of the body. In fact, the majority of share of the blood that should have gone to the lower half of the body will now be going into the upper half of the body, which will result in an upper limb hypertension. So the blood pressure of the arms will be more than the blood pressure of the legs. Plus, these children often have radiofemoral delay. That is, if you simultaneously feel the radial pulses and the femoral pulses will usually be felt after the radial pulses. So upper limb hypertension, feeble lower limb pulses or not palpable pulses of the lower limb, radiofemoral delay, even pain in the calf muscles while walking, pain of intermittent claudication, they all are seen in coarctation of aorta. This is a congenital heart disease associated with narrowing in the aorta distal to the left subclavian artery. To overcome these coarctation or constriction, collaterals often develop. The collaterals, with the aim to overcome the obstruction, develop from the internal mammary artery, which is a branch of the subclavian artery, the left subclavian, and then it also develops from the intercostal arteries. So these arteries, the collaterals, they get enlarged, trying to bypass the obstruction. So there is enlargement of these collaterals, especially the intercostal arteries, which are present below the lower edge of the ribs. So these intercostal arteries, which are present below the lower edge of the ribs, when they enlarge, they often rub the ribs, leading to notching of the ribs. So if you actually see the X-ray, the typical X-ray will be like this, a figure of 3 sign. We call it as a figure of 3 sign, along with notching of ribs. The blue arrow is showing you the serrated margins. The blue arrow is showing you the serrated margins, which is the place where the intercostal arteries have caused notching of the ribs. So figure of 3 sign along with notching of the ribs is the classical X-ray presentation of a coarctation of aorta. So that is why the answer here is coarctation of aorta is the most likely congenital heart disease the child is suffering from. Coming to question number 4. A child is a known case of HIV. His CD4 counts is 50. Which vaccine should be avoided? Ideally, all live vaccines should be avoided in HIV. The logic is very simple to understand that in HIV there is an immunocompromised state, which can often result in a live bacteria or a live virus, which can get reactivated in that immunocompromised environment, ultimately leading to the disease against which you are trying to protect the child against. So BCG, OPV, BCG especially in symptomatic HIV you should not give. Symptomatic HIV means where there are symptoms of HIV. It's still debatable whether you should give BCG at birth or not in these children. Many people say yes, you can. But if the symptoms of HIV have developed, BCG should definitely not be given. OPV, obviously you have an alternative, IPV, which is an inactive vaccine. So why give a live OPV vaccine? The point regarding the measles, mumps, rubella vaccine, even the varicella vaccine, chickenpox vaccine, which again are all live vaccines. They all are also live vaccines and they should also not be given. Hence here the answer should be MMR, should not be given, because MMR is the only live vaccine among the choices given here. But please remember what is recommended is that measles, MMR and varicella vaccine administration in these children should be individualized. So what is recommended is that you have to weigh the benefit versus risk ratio. So if the benefits of giving measles, MMR and varicella vaccine outweigh the risk, and if yes, then you can give or can consider giving these vaccines if in the HIV child the CD4 count is more than equal to 15% or the CD4 count is more than equal to 200 cells per cubic millimeter. So basically measles, MMR and varicella vaccines should also not be given because they are live vaccines. But if their benefits outweigh the risk in an HIV child and the child's CD4 counts are more than 15%, more than equal to 15% or more than equal to 200 cells per cubic millimeter, which means the child is not severely immunocompromised. In those cases, you might consider giving these vaccines, even though as a general rule, all live vaccines are not to be given in a child of HIV infection. So because in question number 4, all the vaccines that they have given are killed vaccines except for MMR, which is a live vaccine. That is why the vaccine which should be avoided is the MMR vaccine. But as I told you, if the benefit risk ratio is considered and the benefits outweigh the risk, in those cases you might consider giving this MMR, measles, varicella vaccine if the CD4 counts are more than equal to 15% or more than equal to 200 cells per cubic millimeter. Question number 5 says a baby presents with tachypnea, fast breathing. In the emergency, he has a carpopedal spasm. Now, carpopedal spasm is a typical feature of hypocalcemia. Normally what happens is there are many reasons why a hypocalcemia can be precipitated. Often what happens is that in cases of hyperventilation, when a child is hyperventilating, a child is having fast breathing, this often can lead to the development of respiratory alkalosis. Naturally, when a child is breathing fast, the CO2 will be washed out. So it will lead to respiratory alkalosis. What does respiratory alkalosis do? It dissociates the hydrogen ion from the albumin in the blood. And this hydrogen ion from the albumin is then bound to calcium. So as a result, because of this, what happens is the ionized calcium in the body, what happens is the ionized free calcium in the body reduces. And this can precipitate features of hypocalcemia. So when the child is hyperventilating, breathing very fast, it leads to CO2 washout or respiratory alkalosis. This results in dissociation of hydrogen from the albumin in the blood, and this hydrogen is then bound to the calcium, leading to a reduced amount of ionized calcium, and that is what leads to hypocalcemia. In my classes, I've told hypocalcemia in a term child is defined as a serum calcium which is less than 8 milligrams per deciliter, while in a preterm child, hypocalcemia is less than 7 grams per deciliter. So these are newborns. What is the definition of hypocalcemia in a child? It is debatable, but probably the more acceptable definition is a serum calcium of less than 8.5 milligrams per deciliter. This is debatable. You might find different values in different books, but in a child, a serum calcium of less than 8.5 milligrams per deciliter is what is called as hypocalcemia. And whenever the calcium becomes low in the body, there are symptoms of twitching of the muscles. Actually, what calcium does is it controls the muscles contraction and the nerve contraction of the muscles and nerves. So when there is a hypocalcemia, there is frequent twitching of the muscles, increased contraction of the nerves. So if you tap over the facial nerve, over the parotid area, it can lead to contraction, twitching over the facial nerve area. This sign is called as the Shostak sign. You must have heard of this in medicine also. If you apply a cuff on the arm and increase the pressure, it will lead to a carpopedal spasm like this, which is known as the Trocheus sign. So all of these are signs of hypocalcemia, and this increased muscle contraction is because of low calcium in the blood. So that is why hyperventilation or tachypnea, how it leads to hypocalcemia, and this hypocalcemia ultimately is leading to the development of a carpopedal spasm. Let us come now to question number 6. Question number 6 says, a 4-year-old child has a ventricular shunt for hydrocephalus and has got it replaced because of shunt malfunction. The child has now presented with irritability and loss of appetite for 3 days, and there is no other symptoms. The rectal temperature was 38.7 degrees centigrade, which roughly becomes around, I think, about 101 degrees Fahrenheit. Just above 101 degrees Fahrenheit. So that means the child has presented to you with fever, and it's a rectal temperature, has presented to you with a fever, has presented to you with irritability, has presented to you with loss of appetite, all of which can be features of meningitis also. And since this meningitis appears to have occurred after the shunt has been replaced for a hydrocephalus, this may be a case of a shunt-associated meningitis. See, for treating hydrocephalus, various types of shunts are introduced. Basically, what is happening in a hydrocephalus is that in the ventricles, the CSF is accumulating. So you have to provide an alternative route through which that CSF from the ventricles can be shunted. One of the most popular shunt which is used for this purpose is a ventriculoperitoneal shunt, which shunts the CSF from the ventricles down into the peritoneal cavity. However, when you use these shunts, you can also use a ventriculoatrial shunt. But when you use these shunts for allowing the CSF to drain into the alternative area other than the ventricles, then there may be many problems associated with shunts. For example, there might be association of shunts with blockage because of the high proteins that may be present, say for example in tubercular meningitis. The shunts may get frequently blocked. So a revised shunt surgeries may be required in such cases. You might also have shunt fractures. The shunts can get broken, which ultimately may again lead to the CSF accumulating. You might have shunt infections. Most of these shunt infections usually occur within 3 months of the shunt surgery. Majority of shunt-associated infections occur within 3 months of performing the shunt-associated surgeries. And these shunt infections often are caused by bacteria such as Staphylococcus aureus, Staphylococcus epidermis. So basically, a shunt infection or a shunt fracture or a shunt block is leading often to complications, and one of that complication can be that there will be increase in the intracranial pressure again. So there might be subtle signs of intracranial pressure getting increased appearing, and in cases of shunt associated infections there might be signs of meningitis reappearing, as appears to be happening in this case. So in this case, the treatment, or rather than first the diagnostic approach that is required, is to do a shunt tap, take out the CSF and evaluate it for the presence of infection. But before you do a shunt tap, a complete CT MRI of the brain is important, including the shunt imagings. Serial shunt imagings along with CT and MRI of the brain may be required. This is what I have discussed with many pediatric neurologists also. And now they have come to the conclusion. I actually thought lumbar puncture is also a very good answer here. But now if I compare a lumbar puncture and a shunt tap, many of my pediatric neurologist friends have said that probably a shunt tap along with a blood culture will obviously be giving better results than doing a lumbar puncture alone for CSF evaluation. So according to me, the best answer here should be perform a blood culture also and perform a shunt tap also, obtain the CSF, send it for culture, start empirical antibiotics. In case meningitis is diagnosed, you have to treat that meningitis, giving appropriate antibiotics, and then a repeat shunt surgery is required or may be required. So this is one of the known complications of putting in shunts in children with hydrocephalus. Coming to question number 7, a 12-year-old kid was taken to a hospital with fever and fatigue. His chest X-ray imaging is shown, which very clearly shows a picture of figure of 8 appearance or a snowman's heart. So this is a typical snowman's heart appearance, which is seen in total anomalous pulmonary venous return or total anomalous pulmonary venous connection. I've often told this in my classes that sign of 3 is seen on chest X-ray in coarctation of aorta. A boot-shaped heart is seen in children with Tetralogy of Fallot. Egg on string appearance is seen in a TGA. A snowman's heart or figure of 8 appearance is seen in TAPVR or a TAPVC, and a box-shaped heart is seen in Epstein's anomaly. Now, since in this case we are seeing that there is a figure of 8 appearance or a snowman's heart appearance, it usually indicates a TAPVR, especially a supracardiac variety of TAPVR, which is the most common variety of TAPVR. Here all the 4 pulmonary veins, after joining together, they form an ascending vertical vein, pass above the heart and then open up into the right atrium. So that big vertical vein forms a swelling on the left side, and because that big vertical vein is draining into the superior vena cava, which ultimately then drains into the right atria. So the superior vena cava swelling also leads to a swelling on the right side on the X-ray. That is why you get a shape of the snowman's head, and below the enlarged heart makes up the snowman's body. That is why we get a snowman's heart appearance in a supracardiac TAPVR or a TAPVC. TAPVC means total anomalous pulmonary venous connection, which is the other name for total anomalous pulmonary venous return, TAPVR. It's a cyanotic heart disease associated with increased pulmonary blood flow. Coming to question number 8, intersusception is a complication which is often seen after rotavirus vaccine. And this is a pretty simple question, because I think among all the vaccines that we are using currently in the national immunization schedules or in the IP immunization schedules, probably it's only the rotavirus vaccine which has a known history of intersusception risk. Especially the first rotavirus vaccine that was available in the market, RotaShield, that was the vaccine which was associated with a significantly high risk of intersusception. The risk of intersusception with the current rotavirus vaccines. The current rotavirus vaccines are the human monovalent live rotavirus vaccine, which comes by the name of Rotavirus. And then we have the human bovine pentavalent rotavirus vaccine, the Rotatic. Then we have the neonatal rotavirus vaccine, which is based upon the 116E strain. And then we have the bovine rotavirus vaccine. So these are the rotavirus vaccines which are currently available, and they are comparatively much safer than the rotavirus vaccine which was first introduced, RotaShield. That actually had a significantly high risk of intersusception, where one part of the intestine it telescopes into the other part of the intestine. So that was the reason why RotaShield vaccine had to be withdrawn from the market. These vaccines are relatively safer. However, caution needs to be exercised when this vaccine is given, particularly because of the risk of intersusception. So all children who are at a high risk of developing intersusception, this vaccine should be given with caution or should be actually avoided if there is a definitive risk. Which is the drug which is useful in a severe COVID infection? See, in a severe COVID infection, first of all, COVID infections may be mild COVID infections, moderate COVID infections, and severe COVID infections. Mild COVID infections usually will have only mild symptoms of COVID without any fast breathing. In moderate disease, there will be presence of fast breathing, or there might be presence of chest retractions. Oxygen saturation usually is between 90 to 93% on room air. But when the oxygen saturation falls to less than 90%, or there is presence of grunting or severe chest retractions with the development of pneumonias, or there is presence of severe diarrheas, vomitings, abdominal pains, all of this usually indicates that the child may have developed a severe COVID infection. Now, for severe COVID infections, the most important treatment that you need to give is to first admit the child in the high dependency unit or the ICU, and then you have to start the child on oxygen. Most of these children have an oxygen saturation which is less than 90%. You have to start oxygen saturation, and you can maintain this oxygen saturation somewhere around the 95% range. Fluid needs to be given. The only definitive treatment that has been currently approved in a severe COVID infection is corticosteroids. Either you can give intravenous dexamethasone or you can give intravenous methylprednisolone. Probably a methylprednisolone may have a better penetration in the lungs compared to dexamethasone. So many of my colleagues also, they prefer giving IV methylprednisolone compared to dexamethasone in a child of severe COVID infection. But otherwise, you can use dexamethasone as well. Corticosteroids only have a definitive role in the treatment of severe COVID infection. Even in a mild COVID infection, in a moderate COVID infection, it is only recommended when there is signs of deterioration of the disease. Otherwise, there is no known recommendations to give corticosteroids in mild or moderate COVID infection. In moderate COVID infection, it only is recommended when there is signs of deterioration towards a severe disease. But corticosteroids are definitely required in children with severe COVID infections. Anticoagulants can also be given in case there is evidence of increased risk of thrombosis. If there is an evidence of co-bacterial infection, you can give antimicrobials, and in case acute respiratory distress syndrome or shock develops, you have to treat that. So definitive treatment of severe COVID infection among these is only steroids. Remdesivir, according to the government guidelines, have no role in the management of children less than 18 years of age, management of COVID infections. In some guidelines, they recommend that it can be individualized in children only in the hand of experts. But as far as I know, the government guidelines very clearly are of the view that remdesivir in young children should not be used. Ivermectin now doesn't have any role in the management of severe COVID infections. Coming to question number 10. Question number 10 is, which of the following is correct for components of Kangaroo mother care? Now, Kangaroo mother care is a form of care that is given particularly for low birth weight infants, and that too for stabilized low birth weight infants. And it is basically a best way of keeping a child warm, particularly a low birth weight child warm. It's a form of prolonged skin-to-skin contact, early initiation of breastfeeding, and early discharge from the hospital. So it's a form of a prolonged form of skin-to-skin contact. When I say prolonged, that means minimum 1 hour. Early initiation of exclusive breastfeeding and timely discharge from the hospital and continuation of this breastfeeding at home. You can say it's a standard of care for low birth weight babies to keep them warm, especially stabilized low birth weight babies with a weight of more than 1.8 kgs. Should be continued till the child outgrows 2.5 kg weight, so his weight now becomes more than 2.5 kgs, or the child has now become more than 37 weeks of gestation. So it's a standard of care to keep low birth weight babies warm, Kangaroo mother care, and I've often taught this in my classes. Pentavalent vaccine, again a straightforward question. The national immunization schedule recommends a combination of DPT, hepatitis B and Hib, which is a pentavalent vaccine. Pentavalent vaccine is a combination of DPT, hepatitis and Hib, diphtheria, pertussis, tetanus, hepatitis B and Hib. 0.5 ml of this vaccine is given intramuscularly. The hepatitis B first dose is to be given at birth, but in the national immunization schedule, the subsequent doses at 6, 10 and 14 weeks of hepatitis B needs to be given in combination with DPT and Haemophilus influenza B as a pentavalent vaccine. So pentavalent vaccine given at 6, 10 and 14 weeks, 0.5 ml intramuscular dose. It's a combination of DPT, hepatitis B and Hib vaccine. Which of the following is a true statement about congenital cytomegalovirus infection? See, congenital cytomegalovirus infection is overall the most common congenital infection that is seen in children. The classical triad of this infection is a microcephaly, intracranial calcifications and chorioretinitis. These children may present with IUGRs also. They may present with other problems such as sensorineural hearing loss also. But the classical triad is always a microcephaly, intracranial calcifications and chorioretinitis. So this statement that the classical triad of congenital CMV is sensorineural hearing loss, periventricular calcifications and enamel hyperplasia is a wrong statement. Then 90% of children who have congenital CMV are without symptoms. Only 10% are symptomatic. So for us to say 20 to 30% children with CMV are symptomatic, this is wrong. Only 10% children are symptomatic. 90% children with congenital CMV are without any symptoms. Now, among the other complications, including vision loss, mental retardation, developmental delays, sensorineural hearing loss is very important in these cases. In fact, congenital CMV is considered to be the most common non-syndromic cause of sensorineural hearing loss in children. And that is the reason why ganciclovir often needs to be started as soon as this condition is diagnosed. Now, the problem is that children who are symptomatic, they are more likely to develop a sensorineural hearing loss. As you can see, only 13.5% of asymptomatic infants develop sensorineural hearing loss. This means that if a child doesn't have symptoms and is suffering from congenital CMV, that does not mean at birth if he is not having symptoms, he may not develop sensorineural hearing loss. But the risk is much higher in a child who is symptomatic, where the risk of developing sensorineural hearing loss can almost be around 40 to 58% compared to a 13.5% risk in children who are asymptomatic. So for us to say that children who are asymptomatic, most of them go on to develop sensorineural hearing loss later, this is wrong. Risk is definitely there, but the risk is much higher in children who are symptomatic in comparison to children with asymptomatic. Only correct statement is his. If the mother has IgG positive antibodies for CMV, then she is less likely to develop infection or transmit this infection to the child compared to a mother who doesn't have CMV. That means she is not been previously infected with CMV. As you can see, mothers who develop a primary CMV infection are naive. They have never developed CMV in the past. They have a risk of almost around 30 to 40% of transmitting the disease to the child. But if the mother has IgG positive CMV, that means she has previously been exposed to CMV, then the risk just reduces down to around 1 to 3%. So previous exposure characterized by the presence of IgG antibodies will lead to a very reduced risk of just around 1% or 3%. But if there is naivety, no previous history, primary CMV infection, then the mother has a very high chance, almost around 30 to 40%, of transmitting the disease to their infants. So the only correct statement in question number 12 is D. A is also wrong, B is also wrong, C is also wrong. The only correct statement is choice D. Coming to question number 13, the most common cause of death in a child between 1 to 4 years of age, and they have asked to put this in a sequence. See, under 5 mortality as given, I'm just giving you the statistic that is given in OPGHI. In OPGHI, there is mortality statistics that are given in children under 5 years of age, and the most common causes of deaths in under 5 are preterms and its complications, accounting for almost around 24% of the total mortalities that occur in under 5 children. Pneumonias account for about 13% and diarrheas around 11% deaths. So pneumonias account for 13% deaths, diarrheas account for around 11% deaths. Perinatal asphyxias account for 11% deaths, 5% are other neonatal complications, congenital malformations 4%, malaria accounts for 3%, injuries account for 3%, and meningitis accounts for 2%. So among the factors that they have given, pneumonia definitely is the most common, followed by diarrhea. So A more common than B, and only choice that I am getting where A is more common than B is choice B. As such, malaria and injury accounts for 3% of total mortalities in under 5. But pneumonias account for 13% mortalities and diarrheas account for around 11% mortalities. That is why in question number 13, the best answer to choose is B. So these are the under 5 mortalities that are seen in children. And please remember, the most common cause of under 5 mortalities are preterms and its complications. In question number 14, there is a history of a child who is presented with fever and vesicular lesions on the upper limb and in the lower limb along with neck stiffness. So there is a history of neck stiffness, and there are vesicular lesions that are present in the upper limb also and in the lower limb also. Now similar lesions are present on the palms, the soles, and in the oral cavity. The CSF analysis shows normal glucose levels and elevated lymphocytes and proteins. So lymphocytes are increased, proteins are increased in the CSF, glucose is normal, which goes in favor of a viral meningoencephalitis or a viral meningitis. So this appears to be case of a viral meningitis or a viral meningoencephalitis. So if you see the choices, tubercular meningitis, bacterial meningitis as such are ruled out. Now we have two options left. Either it can be a herpes simplex meningoencephalitis, or it can be a Kawasaki viral meningitis along with hand, foot and mouth disease. According to me, the best answer here is Kawasaki viral infection with hand, foot and mouth disease because of the typical presentation of the rashes in the hands, palms, in the soles, in the oral cavities. And this is how hand, foot and mouth disease presents. Hand, foot and mouth disease typically presents with these painful vesicles which are present in the oral cavity. So there is inflammation of the oral cavity along with these painful vesicles. Plus there are these vesicles that are present on the hands and feet also, the palms and soles also. This disease is most commonly caused by Coxsackie A16 but can be caused by other viruses such as enterovirus A71 also. But overall, Coxsackie virus A16 is the most common cause of hand, foot and mouth disease. Meningoencephalitis, although it is rare, it may be present in these children, and we have a meningoencephalitis in our case also. And since the CSF findings in our case are matching the CSF findings of a viral meningoencephalitis, that is why, according to me, the answer to our question should be a hand, foot and mouth disease which has led to the development of a meningoencephalitis. It's not a common complication, but it is nevertheless a known complication which can occur after a hand, foot and mouth disease. So therefore, the answer in our question is possibly the child having a hand, foot and mouth disease followed by the development of a meningoencephalitis. Question number 15, which of the following is seen in a physiological jaundice? So this is a pretty simple question. When there is jaundice, particularly a physiological type of a jaundice in newborns, which is usually because of immaturity of the liver, predominantly to conjugate the bilirubin at birth. So what will happen is the indirect bilirubin levels will increase. The direct bilirubin levels will not increase. That's the indirect bilirubin levels that will increase. The reduced products of this bilirubin, which is urobilinogen, will also increase in the urine. But there will be no bilirubin in the urine. So if you see absent bilirubin in the urine is present in all these four choices, we have to now take out the choice in which there is increased indirect bilirubin and increased urobilinogen. Increased indirect bilirubin and increased urobilinogen are seen in choice B. Therefore, the best answer according to me is choice B. So whenever there is a physiological jaundice in newborns, it leads to an increased synthesis of increased breakdown of hemoglobin into bilirubins. Now this bilirubin is not being conjugated by the liver because the primary problem in neonates who have physiological jaundice is that the liver is unable to synthesize the bilirubins because of immaturity. The immaturity is more in premature infants, less in mature infants. That is why physiological jaundice is more commonly in preterms in comparison to terms. Yet, the main problem is immaturity of the liver, which is unable to conjugate the bilirubins. So, increase amount of indirect bilirubin, increase amount of urobilinogen. Urobilinogen is a reduced product of bilirubin. And there will be absence of the bilirubin in the urine. That is why in question number 15, the best answer according to me is choice B. Coming to question number 16. Now again, this is something which is very, very clear. Meconium is the first stool of a newborn. And I have told very clearly in my classes that the first stool is passed in 24 hours and the first urine is passed in 48 hours. So that is why according to me the best answer should be meconium is passed within 24 hours. The first stool of a newborn, which is the meconium, is usually passed in 24 hours and the first urine in a newborn is passed within 48 hours. But you have to remember one thing. Although the first stool of a newborn, meconium, is passed within 24 hours, usually, but 99% newborns pass meconium in 48 hours. That is why you should start investigating a newborn for not passing meconium only if the child has not passed meconium even by 48 hours. We expect the meconium to be passed by 24 hours. But you should start investigating the newborn for delayed meconium passage only if the newborn has not passed meconium even by 48 hours. Question number 17, pulmonary plethora. Plethora means increase in the pulmonary blood flow. When I say pulmonary plethora, it normally means increase in the pulmonary blood flow. Now this obviously cannot occur in TOF because in TOF you have four components: right ventricle hypertrophy, pulmonary stenosis, VSD and aorta overriding the VSD. Because of pulmonary stenosis which is present in TOF, the pulmonary blood flow will be decreased. So there will be decrease in pulmonary blood flow. Similarly, in pulmonary stenosis also there is a decrease in the pulmonary blood flow. DORV is a double outlet right ventricle. What is DORV? It is a double outlet right ventricle. That means a right ventricle in which both the aorta and the pulmonary arteries are arising from the right ventricle only. Normally from the right ventricle only the pulmonary artery arises. But when both the aorta and the pulmonary artery arise from the right ventricle, we call it as a double outlet right ventricle, DORV. And there is a VSD which is present in most cases. So either the aorta can arise from above the VSD, then we call it as sub-aortic VSD. That means VSD is below the aorta. Or sometimes the pulmonary artery can be above the VSD. So we call it as sub-pulmonic VSD. That means the VSD is below the pulmonary artery. But there will be no increase in the pulmonary blood flow that will occur in a double outlet right ventricle. Normally, because right ventricle is having connection with, suppose, the pulmonary artery also. So when the right ventricle will send the blood into the pulmonary artery, obviously the left ventricle will send the blood into the aorta. So there is unlikely to be an increase in the pulmonary blood flow in a double outlet right ventricle. The important condition that can be associated with a double outlet, with the increase in the pulmonary blood flow, which I have told in my classes also, is a total anomalous pulmonary venous connection. In fact, in my classes, when I have written about congenital heart disease classifications, I have written some conditions which can be associated with increased pulmonary blood flow in cyanotic heart diseases like TGA, like TAPVR, like transposition of great arteries, like truncus arteriosus. So these are conditions or congenital heart defects in which the pulmonary blood flow is increased. in a TAPVC, total anomalous pulmonary venous connection, it's very easy to understand why the pulmonary blood flow will be increased, because all the 4 pulmonary veins which should have opened into the left atria are now opening into the right atria. So the right atria, which normally receives the superior vena cava and the inferior vena cava, is now in addition receiving the 4 pulmonary veins also. So now there are 6 veins which are opening. 6 veins. 6 veins which are opening into the right atria. And all this large amount of blood from the right atria will enter into the right ventricle. Some of it will enter into the left atria also through the foramen ovale. Remaining will enter into the right ventricle and will naturally go to the lungs. So the pulmonary blood flow will naturally be increased. So which condition among these is associated with the increase in the pulmonary blood flow? It is total anomalous pulmonary venous connection. In question number 18, there is a question on a 2-year-old boy who is presented with history of fever for 2 days. The child has developed oral lesions as shown in the image below. So what I can see is an erythematous base over which white colored lesions may be present, and this is what is known as the Koplik spots. Koplik spots are the ananthems that are seen in measles infection. Another thing that is giving us a lead to the answer here is that after 2 days of fever, these rashes have appeared. And in Koplik spots, in measles, Koplik spots appear 2 days after the onset of fever. They appear 2 days before the onset of rash and 2 days after the onset of fever. They can be present often opposite the lower second molar teeth. Now, since this appears to be a case of measles, because Koplik spots are seen, hence the most common complication that you will expect in the acute phase of the disease is otitis media, which is the most common known complication of measles, particularly in the acute phase of the disease. So the rashes that you are seeing are Koplik spots. The child is having measles. And the most common complication that is likely to develop in these children is an otitis media. Question number 19 says, a 5-year-old boy presents with complaints of prolonged fever for 7 days with palpable neck nodes. He also has bilateral watery eye discharge. Peeling of the skin over palms are seen for the past 1 day, along with a macular rash over the trunk. Rash is also there. Peeling of the palms is also there. There are lymph nodes also which are there, which are enlarged. So lymph nodes are also enlarged. Fever is also there. Plus there are features of conjunctivitis also. Everything points out to the fact that this child possibly is having a Kawasaki's disease. Kawasaki's disease is a type of medium vessel vasculitis in children. It's a very common type of vasculitis of childhood, which I personally would say is only second most common vasculitis of childhood after Hinox-Schwann and purpura. It is characterized by a fever which is more than 38.3 degrees centigrade. Often a remitting fever, not easily controlled with antipyretics, plus associated with some additional problems such as bilateral non-exudative conjunctivitis. Bilateral non-exudative conjunctivitis. Plus there is presence of enlargement of the lymph nodes. Non-suppurative lymphadenopathy, non-suppurative cervical lymphadenopathy. More commonly unilateral compared to bilateral, with the lymph node size usually more than 1.5 centimeters. Plus there is presence of rash. plus there is presence of edema and swelling of the hands and feet. In the acute phase, there is edema and swelling of the hands and feet, followed by peeling of the skin that starts in the subacute phase of the disease. And plus there is presence of oral mucosa inflammation, along with a typical red tongue, which is called as the strawberry tongue. So these are the features: bilateral non-exudative conjunctivitis, non-suppurative cervical lymphadenopathy, more commonly unilateral than bilateral, rash, edema and redness over the hands and feet, edema and redness, not swelling, redness over the hands and feet, oral mucosa inflammation along with a strawberry tongue. All of these are features that are seen in children with Kawasaki's disease. And Kawasaki's disease is famous for its cardiovascular complications. In many parts of the world, it has actually replaced rheumatic heart disease as the most common cause of acquired heart disease of childhood. Particularly myocarditis, which happens to be a very common cardiac complication, and the development of aneurysms in the coronary arteries, which often can lead to aneurysms, thrombosis, and even deaths. Most of these children are below 5 years of age. Kawasaki's is not seen in adults. So this appears to be a case of Kawasaki's disease only. Identify the X-ray. This is typically a very simple boot-shaped heart. And boot-shaped heart is seen in children with Tetralogy of Fallot. I mean, if you see the majority of questions that I have shown, I mean, those who have attended my classes, I mean, 99% of questions that I have shown are the questions that we have covered in our classes. So a person or a student who has attended the classes, has gone through the notes properly and has read these notes properly, it's quite unlikely that they will miss out at least on 99% of the questions. There might be 1 or 2 questions out of the 39-40 questions which I mentioned, which probably might have been not emphasized on, but remaining 99% of the questions, I would say 38 out of 39 questions, we have emphasized in our classes. And this is a case of a boot-shaped heart which is seen in Tetralogy of Fallot. So quite easy way of recognizing this X-ray. Question number 21, embryological basis of Hirschsprung disease. Hirschsprung disease is the most common cause of delayed meconium passage in the newborn. And the reason why this happens is that a portion of the intestine, usually the rectosigmoid portion, doesn't have the ganglions. And why these do not have the ganglions? Because it is usually due to embryological abnormality resulting in a delay or arrest in the migration of these neuroentry ganglion cells. So a portion of the intestine, particularly the lower rectosigmoid portion of the colon, does not have the ganglion cells. So this portion will not be able to contract. It will be collapsed. And when it will not be able to contract, obviously it will not be able to pass meconium, which is the reason why these newborns do not pass meconium in 24 to 48 hours after their birth. Normally what happens is the neuroanterior ganglions, they migrate from the neural crest to the upper part of the alimentary tract, the gastrointestinal tract, and then they start their journey through the vagal fibers caudally into the lower part of the alimentary tract, the gastrointestinal tract. When this does not happen, either there is a delay or this migration does not happen at all, then this will result in Hirschsprung disease. So the cause of this Hirschsprung disease is the failure or a delay in the migration of the ganglion cells into the gastrointestinal tract. There can often be a delay in the ganglionation of the intestinal tract also, as can occur in a condition known as small left colon, which I have told is one of the complications seen in infant of diabetic mothers. There is a delay in the innervation of a part of the intestine, small left colon. That's a complication seen in infant of diabetic mothers. Hirschsprung disease, usually there is total absence of these ganglion cells. And hence this is a condition which needs to be treated surgically. Greenish black thick stool in a neonate is due to meconium. Pretty simple. I mean, there is nothing that I need to tell here. The first stool of a newborn is meconium, and it usually is greenish or greenish black in color. It contains water, amniotic fluid, then it contains bile, it contains the epithelial cells which have been shredded from the intestinal tract, it contains the hairs, the lanigo, it contains some bile. So it is basically a accumulation of all the contents that are present in the intestinal tract of a newborn. And as I told you, 99% of the newborns will pass meconium by 48 hours, although the usual time of passage of meconium in a newborn is 24 hours. But 99% of newborns will pass meconium by 48 hours after birth. So you should start investigating a child for delayed meconium passage if the child has not passed meconium even by 48 hours. A term baby with a weight of 2700 grams, which is 2.7 kgs, the child has been exclusively breastfed and the child has developed now jaundice. So this is now neonatal jaundice, and neonatal jaundice, the child's total serum bilirubin is 14 milligrams per deciliter on day 5 of life. See, normally I always tell in my classes, there is no need usually to remember the normograms, because these are the normograms which can tell you what are the cutoffs of serum bilirubin for phototherapies and exchange transfusion. It's very difficult to remember them. So what these normograms tell, and we have similar type of tables for children less than 35 weeks gestation also. I'm just showing you the normogram which can tell you what are the cutoffs of the total serum bilirubin, which is on the y-axis. What is the cutoff levels above which you will like to do a phototherapy or an exchange transfusion. And these are the child's age. As you can see, we have a separate normogram for phototherapy and a separate normogram for exchange transfusion. For phototherapy, you can see there are three graphs or three graphical representations lines. And similarly for exchange transfusions also, you have three graphical lines. The topmost line is a child who is having a gestation of more than 38 weeks. That means who was born after 38 weeks. And the child has no risk factor. No risk factor for kernicterus, bilirubin induced neurological dysfunction. No risk factor for kernicterus or bilirubin induced neurological dysfunction. The second graph is a graph, the middle one is the graph for a child who is more than equal to 38 weeks but has risk factors for kernicterus. And this is a graph also which should be used for a child who is between 35 weeks to 37 weeks. Let us say 35 weeks to 38 weeks. However, again with no risk factors. No risk factors means for kernicterus. And the bottom graph, this graph, is the last graph, which is for children who are born between 35 to 38 weeks with risk factors for kernicterus. So you have three graphs and you have to put the child in one of these graphs. If the child is born after 38 weeks and has no risk factors for kernicterus, birth asphyxias, hypoalbuminemia, or the child is having a pre-existing encephalopathy, or the child is having RH or ABO incompatibility, blood group incompatibility with the mother. All of this will increase the risk of kernicterus. So any child who is born after 38 weeks or more and has no risk factors for kernicterus should be put in the topmost graph. A child who is born after 38 weeks or more and has risk factor for kernicterus, or a child who is born between 35 to 38 weeks and has no risk factor for kernicterus should be put in the middle graph. And a child who is between 35 to 38 weeks gestation with risk factors for kernicterus should be put in the bottom graph. Once I have decided in which graph I have to put the child on, now I will see the age of the child and I will see the cutoff of total serum bilirubin above which a phototherapy or exchange transfusion needs to be performed. Now, in our case, the child has an age of 5 days. So let us see only for 5 days. And in our case, the child is a full-term child. So that means he's born after 37 weeks. Now, if I see, please see here, if I see the two graphs, the topmost graph and the middle graph, which obviously are for children who are term children. If you see the topmost graph here and the middle graph here, these are the cutoffs of total serum bilirubin above which phototherapy would be required. Now just see these cutoffs. The cutoff for this will be around 21 milligrams per deciliter of total serum bilirubin, and the cutoff for this will be, if you see, around 70 to 80 milligrams per deciliter. That means for a child born after 38 weeks or more without any risk factor, if he has a total serum bilirubin above 21, then that child should be taken up for phototherapy. And in a child who has been born between 35 to 38 weeks without any risk factors, or is born after 38 weeks or more with risk factor for kernicterus, in that child, a total serum bilirubin above 17 to 18 milligrams per deciliter should be taken for phototherapy. But in our patient, if you see, in our patient, the child was a 2700 gram full-term baby. Full-term baby means the child is born after 37 weeks. So that very clearly means that the child has to be either in the topmost graph or in the middle graph. And in both cases, the cutoffs for total serum bilirubin will be either 21 and above or 18 and above. But see what is the total serum bilirubin in our patient. It is 14. So in our patient, right now what I would recommend, no treatment is recommended. As such, I do not recommend remembering these tables and graphs because it is very confusing, and what I believe personally is most of these questions, these type of questions, when they will be asked, they usually will have an answer mostly of no treatment because of physiological jaundice. Now, this is the graph for a child who is more than 35 weeks gestation. We have similar tables for children who are born less than 35 weeks of gestation, which will tell you the cutoffs of TSB, total serum bilirubin, above which phototherapy or exchange transfusions will be performed. So anyway, I have told you why in our patient the answer will be no treatment is required. Coming to question number 24, a child presented with coarse facial features, hypercalcemia and cardiac findings and a murmur which suggests supravalvular aortic stenosis. The moment they say hypercalcemia and a supravalvular aortic stenosis, this very clearly means that the child is suffering from a Williams syndrome. This is a disorder which is associated with mutations which occurs on chromosome 7. Typically, these children have elfin-like faces. So they typically have elfin-like faces. Elfin is the mythological character, and this is elfin-like faces that these children have. It's one of the very, very common causes of intellectual disabilities or mental retardation. So it's a very common cause of intellectual disability or mental retardation. I would say that if you are asked what are the features of Williams syndrome? You can remember it with the mnemonic William. So the weight gain of these children is poor. Iris in these children is stellate shaped. Stellate shape means like a wheel, spokes of a wheel like this. This is stellate shaped. Then you have a large mouth. Then you have a large philtrum. Then you have increased calcium. So there is hypercalcemia. There is aortic stenosis, and the type of aortic stenosis is supravalvular aortic stenosis. Again, this has been always told in my classes. Supravalvular aortic stenosis, commonly seen in Williams syndrome. And M stands for mental retardation or intellectual disability. So weight gain poor, iris is stellate shaped, large mouth, large philtrum, increased calcium, aortic stenosis, and supravalvular aortic stenosis is present in these cases, and mental retardation or intellectual disability. These are the features of Williams syndrome. And in our patient, we have hypercalcemia also, we have supravalvular aortic stenosis also, we have facial abnormalities also. This clearly goes in favor of a child having a Williams syndrome. Coming to question number 25, this is again a pretty simple question. Hyaline membrane disease. Hyaline membrane disease is a disorder due to surfactant deficiency. Hyaline membrane disease is a disorder due to surfactant deficiency, and surfactant is released by the type 2 pneumocytes. Both the type 1 pneumocytes and the type 2 pneumocytes, they are known to be present in the alveoli, lining the alveoli, but it is the type 2 pneumocytes that secrete the surfactant. The surfactant reduces the surface tension and prevents the alveoli, which is a spherical structure, and otherwise the fluid lining the alveoli should have a very high surface tension, should cause the alveoli to collapse. So when you have a lining of surfactant around the alveoli, they reduce the surface tension in the alveoli and hence prevents the alveoli from collapsing. Peak surfactant production occurs by about 34 to 35 weeks of intrauterine life. So any child who is born earlier than 34 weeks will be likely to develop a hyaline membrane disease, and more premature the child is, more is the risk of developing a severe form of hyaline membrane disease. The more important term that we use now for hyaline membrane disease is the respiratory distress syndrome. Question number 26. A 14-month-old child has steroid dependent nephrotic syndrome. Which of the following is true? So there are multiple choices. Now, because a child of a steroid dependent nephrotic syndrome is likely to be first on drugs such as cyclosporin or cyclophosphamide, the steroid dependent nephrotic syndromes often are treated with levomisols. They are often treated with cyclophosphamides. They might be on prednisolone, alternative prednisolone treatment also. All of these are likely to cause immunocompromised state. So the recommendations in nephrotic syndrome are very clear. Because nephrotic syndrome is usually being treated either with steroids or is being treated with immunosuppressive agents like cyclophosphamides, levomisols, cyclosporins. So no live vaccine should be given in nephrotic syndrome till the prednisolone levels, steroid prednisolone dose is below 1 milligrams per kg daily or below 2 milligrams per kg every alternate day. So till the dose of prednisolone is below 1 milligrams per kg daily or 2 milligrams per kg alternate day, no live vaccine should be given to a child, because otherwise these children are immunocompromised, and as I told you, live vaccines can actually be dangerous in such scenario. When I was telling you about HIV, I told you why live vaccines are dangerous in immunocompromised states. Transmissible vaccines, live vaccines such as OPV, which are transmissible from one child to another, these transmissible vaccines should also not be given to the contacts. It's self-explanatory. They are all transmissible. Fecal-oral route, they can spread. So these vaccines should also not be given to the contacts. Flu vaccines every year, and pneumococcal vaccines, because these children have increased risk of infections, especially streptococcus pneumonia is one of the most common infections seen in nephrotic syndromes. So these children should be given their full course of pneumococcal vaccines, and yearly flu vaccines, influenza vaccine should also be given to these children. So according to me, if this is a multiple choice question, B should be correct, C should be correct, D should be correct. A obviously is a wrong statement. All live vaccines can be given is a 100% wrong statement. Nephrotic syndrome, they can be counterproductive. Killed vaccines can be given. Transmissible vaccines such as OPV should not be given, especially to the siblings or contacts, because of the risk of transmissibility by the fecal-oral route. And pneumococcal vaccines, I just know, should be completed. The course of pneumococcal vaccine should be completed, and yearly influenza vaccine should be given in these patients. Question number 27 says a child is diagnosed with hypertrophic pyloric stenosis, which is a disorder associated with hypertrophy of the gastric outlet. So there is a gastric outlet obstruction. So there is gastric outlet obstruction. Which occurs in these cases because the pylorus part of the stomach is hypertrophied. So often it is associated with 3 P's. So there is projectile vomitings, which often start from around 2 to 3 weeks. From around 3 weeks of age, projectile vomiting starts after feeds. Then it is associated with a pyloric mass, and this pyloric mass is typically present in the epigastrium, and it may be present on the right side below the liver. And the third P is peristaltic waves, which may be seen passing from left to right. So there is first projectile vomitings. Now these projectile vomitings may be bilious vomitings, they may be non-bilious vomitings. There will be visible peristalsis that can be seen passing from left to right. So these peristalsis can be seen passing from the left side of the abdomen to the right side, and the main aim or objective is to overcome the obstruction, the gastric outlet obstruction. There will be a palpable mass, which is the thick pylorus, which usually is present in the upper part of the stomach, the epigastric region, or it is seen on the right side below the liver. And because these children often have vomitings, so they will often be having vomitings, which is a very important presentation. So vomiting will lead to washout of the hydrochloric acid from the stomach. It will also lead to loss of potassium in the gastric fluids. So loss of chlorides and loss of potassium, loss of hydrochloric acid will lead to hypochloremic. It will lead to hypochloremic. Hypokalemic, metabolic alkalosis. That is because of the child vomiting again and again. So all the hydrochloric acid is being washed out, which will lead to alkalosis, metabolic alkalosis. And because there is loss of potassium in the gastric fluid also, it will contribute to the development of hypokalemia also. So there will be hypochloremia, hypokalemia, metabolic alkalosis, a large palpable mass, visible peristalsis. Therefore, according to me, the best answer here should be 2, 3, 4 and 5. Bilious vomiting, as I told you, cannot be present, may not be present in these cases. Had the choices been 1, 2, 3, 4 and 5, possibly bilious vomiting may be present in some children. But the only best answer here would be 2, 3, 4 and 5. Question number 28 says a 7-year-old child presented with complaints of bedwetting almost twice a week, and this child is 7-year-old. So this is a case of nocturnal enuresis. Okay, so they are not saying in the evenings or at night this is happening. So I will say this is a case of enuresis. If enuresis will be occurring predominantly at night, then we call it as nocturnal enuresis. Never make a diagnosis of enuresis before 5 years of age, because a complete bladder control is achieved only at 5 years. So this child is 7 years of age and this child is bedwetting. So this is a case of enuresis. The first line treatment of all cases of enuresis is usually behavioral treatment or motivation or conditioning therapy, which is known as bell and alarm therapy. It's a form of a conditioning therapy which often used as the first line treatment for nocturnal enuresis. No need to start drugs as the first line treatment. The first line treatment should always be bell and alarm therapy. Often small sensors attached to the mattress on which the child lies, which goes off, alarm goes off when the child passes the urine in that mattress or bed. So when this happens again and again every night, the child is woken up, taken to the washroom. So over a period of time, the child gets conditioned to pass urine in the washroom only. This is a type of a conditioning treatment. The second line treatment is the use of drugs. The second line treatment is the use of drugs. So first, the drugs that you use are oral desmopressin. Second line drugs that you can use are the anticholinergic agents, such as tolterodines, oxybutanins, and the third line drugs that you can use are imipramines. The tricyclic antidepressant given in very small doses. So the initial treatment should always be conditioning treatment like bell and alarm therapy. Do not start the drugs as the first line treatment for enuresis in children. Drugs should always be used as the second line treatment. The first line treatment should be a conditioning treatment, which is known as bell and alarm therapy. Question number 29 says, which of the following is true about a fragile X syndrome? Now, fragile X syndrome is one of the very, very important causes of intellectual disability in children, mental retardation. It's actually the second most common cause after Down syndrome, second most common cause of intellectual disability, and the most common inherited cause of intellectual disability in children. Fragile X syndrome basically is associated with the fragile site on chromosome X, and this is associated with expansion of the CGG repeats. Expansion of the CGG repeats, allelic expansion of the CGG repeats occurring on the FMR1 gene, which is the classical site where this expansion will occur. So it's a repeat of the CGG sequence. This allelic expansion is what is causing the Fragile X syndrome. And there are so many problems associated with Fragile X syndrome, but the most important feature of Fragile X syndrome, especially in boys, this is problem in boys, it leads to mental retardation, intellectual disability. It's the most common cause of inherited intellectual disability, and overall the second most common cause of intellectual disability after Down syndrome, the genetic cause. Otherwise, the intellectual disability which is present in these children may vary from a very mild intellectual disability often to a very severe intellectual disability. So there is a continuum on which the intellectual disability may vary in boys. Females usually are normal. Most female heterozygotes are actually normal. Females are unlikely to be affected. They are mostly having normal intelligence. It's the males who usually have intellectual disabilities. And usually an average IQ, I have highlighted in yellow also, of about 40 that is seen in males. And that also is seen when there is a complete silencing of that FMR1 gene because of that allelic expansion. So if you are asked which of the following is a true statement, it's CGG sequence expansion which occurs, not CAG. So A is wrong. Female, as I told you, female heterozygotes usually are normal. So this again is wrong. Gain of function mutation is not the cause. It's allelic expansion that's the cause. So the most likely answer which is correct is that an average IQ of the males is around 40. Here it's written average IQ males have an IQ of 20 to 40. So I think this should be the best answer here. And remember Fragile X syndrome because of the term intellectual disability in children. Overall, second most common cause of intellectual disability, genetic causes after Down syndrome, most common inherited cause of intellectual disability in children. Question number 30 is on APGAR score, which again I've told in my classes, APGAR score is one of the best ways to evaluate the newborns after birth. Usually it's calculated at 1 minute and 5 minutes after birth. 1 minute and 5 minutes after birth. We are evaluating the newborn on 5 criteria: the appearance or the color of the child, the heart rate of the child, the reflex response of the child, then the tone of the child, overall activity level of the tone, and finally the respiration of the child. If the APGAR score of the child is less than equal to 3, then we call it as a severely depressed child, which again I've told in my classes. If it is between 4 to 7, we call it as a moderately depressed child. And if it is more than 7, then we call it as a normal child. So because here they are saying APGAR score of 3. So 3 or less than 3 usually means a severely depressed child. In fact, if the APGAR score is less than 3, then it may be an early indication of the presence of a perinatal asphyxia. Child not crying at birth, APGAR score less than 3 at 1 and 5 minutes may indicate presence of asphyxia. In fact, if the APGAR score is less than 3 at 5 minutes, it may indicate a very severe asphyxia in children. So if the APGAR score is between 0 to 3, it means a severely depressed child. If it is between 4 to 7, it means a moderately depressed child. And if it is more than 7, it means a normal child. Where do you look for a preductal oxygen saturation? See, when the patent ductus arteriosus is present, that means after birth the ductus arteriosus has not closed. So ductus arteriosus, as you must be knowing very well, is a connection between the aorta and the pulmonary artery. So this orange colored structure is the ductus arteriosus. It's a connection between the aorta and the pulmonary artery. The aorta, this is the right subclavian artery. This is the left carotid artery. And this is the left subclavian artery. Now, normally this ductus arteriosus, which I have shown as a yellow line, orange line, this should close after birth, probably when the child starts breathing high oxygen in the environment. So high oxygen in the environment is a very strong stimulus trigger for the closure of ductus arteriosus after birth. Now, if this stimulus is absent, that means the child is still in a respiratory distress after birth, newborn, and is not able to breathe properly. So the pulmonary vessels will not vasodilate. The pulmonary pressure, which is very high during the fetal period, that should fall after birth. That does not happen. So the pulmonary pressures remain very high. And when the pulmonary pressures will remain very high, the pulmonary artery pressure will obviously remain very high. Second, this respiratory distress, first it will prevent the pulmonary pressures from falling. Second, it will actually also prevent the ductus arteriosus from closing. So this will result in a ductus arteriosus remaining open after birth and allowing a right to left shunting through the ductus arteriosus. This condition is called as a persistent pulmonary hypertension of the newborn. In short, we often call it as PPHN, persistent pulmonary hypertension of the newborn. So that pulmonary pressures that are very high in the fetal period because of pulmonary vasoconstriction state and should have fallen, they have not fallen. And as a result, the pulmonary pressures remain high even after birth. That is why we call it as a persistent pulmonary hypertension of a newborn. It can be a consequence of any cause such as respiratory distress syndrome, Meconium aspiration syndrome, congenital diaphragmatic hernia, wherever there is a respiratory distress in a newborn after birth. Many times the cause remains unknown. That form of PPHN is called as idiopathic PPHN. But whatever is the cause, because the pulmonary pressures are high, the pressure in the pulmonary artery will be high, which will promote a right to left shunting through the ductus arteriosus. So this will result in the lower half of the body becoming blue, because when there will be deoxygenated blood after birth, which will pass from the pulmonary artery into the aorta, the lower half of the body will become blue. So if you measure the oxygen saturation in the foot, which here is the descending aorta, you will get lower oxygen saturation compared to the oxygen saturation that you will get in the preductal area. This is the place where the ductus arteriosus is arising. I will call this as the ductal area. The ductal area is the area where the ductus arteriosus is attaching to the aorta. So any portion above this will be called as the preductal area. Anything below this will be called as the postductal area. So foot often is taken as the postductal area. So if I measure the oxygen saturation in the foot, it is called as postductal oxygen saturation. If I measure the oxygen saturation in the right arm, it is called as pre-ductal oxygen saturation. So the oxygen saturation of the foot is called as post-ductal saturation. Oxygen saturation in the right arm is called as pre-ductal saturation. Now many students ask me, sir, why can't we take left arm as left arm is also pre-ductal? Left subclavian is above the ductus arteriosus. Yes, it is right. But sometimes as a normal variant, that means a variant of normal, the ductus arteriosus, rather than attaching distal to the left subclavian, can be attached proximal to the left subclavian. Then in that case, left subclavian will become postductal. Normally the ductus arteriosus is attached distal to the left subclavian, but in a few percentage of children, the ductus arteriosus may be attached in the aorta proximal to the left subclavian. Then the left subclavian will become postductal. So to prevent that confusion, the best place to take the preductal saturation is always the right arm, because right subclavian will always remain preductal. Left subclavian can become postductal, but right subclavian will always remain preductal. That is why the best place where you can measure the preductal oxygen saturation is the right upper limb. And the best place where you measure the postductal saturation is the foot. And there will always be a difference between the preductal and postductal saturations seen in PPHN. That is one of the diagnostic feature of PPHN. A differential oxygen difference where the preductal oxygen saturation will be more compared to the postductal oxygen saturation. Question number 32 says bidextrous grip. When the child starts catching objects using both hands, that is called as bidextrous. When the child catches objects using one hand, we call it as unidextrous grip. So bidextrous is when the child is using both hands to catch the objects, usually develops in children at 4 months, while a unidextrous approach, when the child starts catching objects using one hand, develops at 6 months. So I would say, some people say bidextrous approach at 5 months, but I would say bidextrous approach at 4 months, a unidextrous approach at 6 months. A severe acute malnutrition as per WHO criteria. This again in my classes I have mentioned. Any child who is between 6 to 59 months of age, any child who is between 6 to 59 months of age who satisfies any one of these three criteria, any one of these criteria, if it is satisfied in a child between 6 to 59 months of age, we will say the child has a severe acute malnutrition. So the weight for height of the child below 3 Z score or 3 standard deviation below the growth, normal growth. Mid-arm circumference less than 11.5 centimeters and presence of bilateral nutritional edema, particularly in the legs. So weight for height less than 3 Z scores or less than 3 standard deviation, bilateral nutritional edema, and a mid-arm circumference less than 11.5 centimeters. Any one of these three criteria is present in a child between 6 to 59 months of age, we will say the child has a severe acute malnutrition. So here the best answer is weight for height less than 3 standard deviation. Second criteria, mid-arm circumference less than 11.5 centimeters. Third criteria, bilateral nutritional edema, particularly in the legs, pedal edema. Any one of these three criteria, if present in a child between 6 to 59 months of age, we call the child as a case of a severe acute malnutrition. Something which I have taught in my classes. Question 34, which vaccine is given every year? It's very, very simple answer, influenza vaccine. Influenza vaccine is given every year. Because the influenza virus strains, they keep changing because of the phenomena of genetic drifts, shifts and genetic drifts. So whenever you give an influenza vaccine in one particular year, it may not be useful because of the change in the genetic framework or genetic copy of the child, not genetic copy of the child, genetic copy of the virus, which is prevalent in the next year. So the virus may become separate or a different type of a virus because of a different type of a genetic copy or a change in a genetic copy, which will make a influenza vaccine used in the previous year ineffective. So all influenza vaccines, they can be inactive influenza vaccines also, and they can be nasal influenza vaccines also, which is a live attenuated vaccine. All inactive influenza vaccines should be started from 6 months of age and should be given till the age of 5 years. Influenza vaccines need to be repeated every year. Chickenpox vaccines, hepatitis A vaccines, hepatitis B vaccines, they have a definitive course. Chickenpox vaccine has a definitive course, 2 doses. Hepatitis B vaccine has a definitive course, birth 6 months, 10 weeks, birth 6 weeks, 10 weeks, 14 weeks. Hepatitis A vaccines, in case we are giving a live hepatitis A vaccine, single dose. In case an inactive hepatitis A vaccine, then we have 2 doses. But then you do not need to repeat them every year. Influenza vaccines, because of the change in the genetic copy of the virus, which is prevalent every year, the vaccine that you have used in the previous year may not be effective in the next year. That is why influenza vaccine needs to be repeated annually. And usually that is needed in children till 5 years of age. After 5 years of age, it's only those children who are at a high risk of developing influenza related problems. Nephrotic syndrome children, children who are on long-term aspirin treatment, they are at a risk of Ray's syndrome. Children who have chronic lung diseases or chronic heart diseases, these are the children who are high risk children. They, after 5 years, should be then given the influenza vaccine. Otherwise, routinely, only till 5 years of age, influenza vaccine is required. Question number 35 says, which of the following is not included in a triad of necrotizing enterocolitis? Now, necrotizing enterocolitis is a complication that is seen in preterm infants. Those preterm babies who have been started on top milk, formula milk, and because of the prematurity, they are predisposed to develop intestinal ischemias. And these intestinal ischemias, along with infections of the intestine, which are due to formula milk being given, not breast milk, so they result in the development of an intestinal inflammation, which is called as necrotizing enterocolitis. 90% NECs occur in preterm. So it's a complication primarily of preterms. These children often have abdominal distension, increasing gastric residues, reduced bowel sounds. Many of them may be associated with systemic signs such as lethargies, poor perfusions, hypotensions, bradycardias, temperature instabilities. And the classical lab markers that are seen in NEC are anemia, thrombocytopenia, neutropenia. So practically they have anemia also, neutropenia also, and thrombocytopenia also, along with a left shift of neutrophils, metabolic acidosis, and hyponatremia. So anemia, thrombocytopenia, neutropenia, left shift of the neutrophils, metabolic acidosis, and hyponatremia. Metabolic acidosis often may be because of the severely reduced perfusion that develops in the intestinal ischemia, and it is also known to occur because of the bacteria, the growth of the harmful bacteria in the intestine, which is causing the oxidation of the substrates, which leads to the release of lactic acids and propionic acids, which leads ultimately to the development of metabolic acidosis. The real reason of metabolic acidosis remains unknown, but it can be because of the bacterial action also on the substrates that are present in the intestine, plus also partially because of the reduced blood flow to the intestinal ischemia that is seen in preterm babies. So anemia, neutropenia, thrombocytopenia, hyponatremia, metabolic acidosis, left shifts of the neutrophil. So these are common problems that can be seen in necrotizing enterocolitis. So they may have thrombocytopenia, metabolic acidosis, hyponatremia, but they are unlikely to have hypokalemia. Anemia, leukopenia, thrombocytopenia, then metabolic acidosis, hyponatremia. Hypokalemia is not a feature of necrotizing enterocolitis. Then the abdominal mass swelling of pyloric stenosis can be best felt. I was telling you about hypertrophic pyloric stenosis, which is characterized by the 3 P's. And this pyloric mass, which I told you, which develops in the epigastrium or on the right side just below the liver, is best felt when the child is being given milk. So this mass, which is the thickened pylorus, is seen in the epigastric region or on the right side below the liver in the infants. And it is usually best felt when the child is being given milk. It can also be often seen in children along with peristaltic waves passing from left side to the right side. Even after a vomit, sometimes this can be easily seen. After a vomit, what happens is the guarding of the abdominal muscles is reduced. So that mass can become very prominent in hypertrophic pyloric stenosis. But the best time when this mass can be seen or felt is when the baby is being fed milk. The time gap between 2 live vaccines. See, the idea is both live vaccines should either be given together, or if the live vaccines are not being given together, they should be given 4 weeks apart. The reason is that if you give live vaccine, one live vaccine now and the other live vaccine within a period of say 2 days, 3 days, the generation of the antibodies, the immunological response to one vaccine may interfere with the immunological response to the other vaccine. So to prevent that interference, where the immune response due to one live vaccine interferes with the immune response of the other vaccine, you should ideally give both the vaccines on the same day. And if you are not able to give them on the same day, you can give them 2 days, you can give them 4 weeks apart. Ideally, you should give them 4 weeks apart. Never give them within a 4 weeks period, because that can result in interference of the immune response between the 2 vaccines, making the vaccines ineffective, because the vaccines work by the immune response method. How many antibodies are formed in response to that vaccines. So if you are interfering with the immune response, naturally the vaccines will become either partially effective or will become totally ineffective. Which of the following frontals is the last to close? I have always said this. The posterior frontals normally are the first to close. They close at 0 to 3 months, followed by the closure of the sphenoid frontals, which close between 3 to 6 months, followed by the closure of the mastoid frontals, which close between 6 to 18 months, and the last frontal to close is the anterior frontal, which closes between 80 to 24 months. So which is the last frontal to close? It is the anterior frontal, which closes between 80 to 24 months. The first frontal to close is the posterior frontal, which closes between 0 to 3 months. So 0 to 3 months, 3 to 6 months, sphenoid frontal. Mastoid frontal closes by 6 to 18 months. The last frontal to close is the anterior frontal, which closes by 18 to 24 months. And this again I have told in my classes. And last question, which is question number 39. A 1-year-old child weighing 6 kg is suffering from acute gastroenteritis along with signs of sunken eyes, and skin pinch goes back within 2 seconds. So this is definitely a case of dehydration. There is incomplete evidence to show that this is severe dehydration. This could have been some dehydration also, but all the options given are in terms of IV fluids. So we take it into account that this is a case of severe dehydration. Now, as far as I know, please remember this, as far as I know, in severe dehydration, children who are less than 12 months have to be given 30 ml per kg of IV fluid over 1 hour and 70 ml per kg of IV fluid over 5 hours. But children who are more than equal to 12 months have to be given 30 ml per kg of IV fluid over half an hour and 70 ml per kg of IV fluid over 2.5 hours. So important thing is, in children who are 12 months or more, as far as I know, but this remains controversial because in some books they write this, in some books they write in children less than equal to 12 months. But I have always followed this for my exams, that for giving IV fluids, which is the treatment of choice for severe dehydration, and ringer lactate usually is preferred, the first 30 ml per kg should be given over 1 hour and 70 ml per kg should be given over 5 hours in a child who is less than 12 months of age. But if the child is 12 months or more than 12 months, that means 1 year or more than 1 year, in those cases, you can give IV fluids faster. So 30 ml per kg can be given over half an hour and 70 ml per kg can be given over 2.5 hours. But if you see the options here, all the options are in first hour. So there is no option of half an hour. So all options are 30 ml per kg over 1 hour. So that is why I actually stick to this option, where 30 ml per kg should be given over 1 hour, 70 ml per kg should be given over the next 5 hours. And what is the weight of the child? Weight of the child is 6 kg. So my best answer will be 180 ml should be given over 1 hour and 6 multiplied by 70. 6 multiplied by 70. 420 ml should be given over a period of 5 hours. If these options would not have been given, I would have answered this as 180 ml is given over a period of half an hour and 420 ml should be given over a period of 2.5 hours. Because this is a child who is 1 year of age. But yes, because this child is a case which appears to be a case of malnutrition also. So slower fluids would be preferred. That is the reason probably what I feel is that they have given 30 ml per kg over 1 hour, 70 ml per kg over 5 hours, because this child appears to be malnourished also. And malnourished children, you definitely should not give faster fluids. So there is still a controversy how you should treat children of severe dehydration who are 12 months of age. Should you put them in the first category that I mentioned, or should you put the children under the second category that they have mentioned? I will personally use, if the child is not malnourished, I will personally use the second category for giving IV fluid in a child of severe dehydration. But here the best answer can only be 180 ml over 1 hour and 420 ml over 5 hours, because there is no category or no option of half hour and 2.5 hours here. And as such, as I told you, because this child is a case of malnutrition, the most likely reason why they have given 1 hour and 5 hours is because most malnourished children should be given IV fluids much slowly. In fact, the only main indication of giving IV fluids in dehydration in a malnourished child is when the malnourished child is in a case of shock. Otherwise, oral fluids should be used for treating dehydration in all malnourished children. So with this, I finished all these questions. I hope you have understood these questions. As you can very clearly see, those who have attended the classes, pediatric classes of my last few years, nearly all the questions are the questions that have been taught or discussed. All the topics have been discussed in my classes. So if you have been a student who has been hearing the classes, who have been making notes properly, and who have read the topics properly from the books also, from my classes also, and I've gone through the app possibly also. There also a lot of this content is already available in the form of notes in my app also. So I think now it's pretty simple. If you attend your classes properly or you go through your books properly, then there is nothing that can stop you from clearing these exams. With these words, I thank you very much for being an attentive listener to this platform and being able to being attentive and going through the whole session and seeing the answers that I provided and the explanations that I provided to all these questions. So thank you very much and goodbye.